Today I'd like to talk about the perioperative management of patients on anticoagulants. In the years that I've been in practice, this topic has become ever more important. The number of anticoagulant drugs seems to increase yearly, and the number of patients taking these drugs is increasing as well. And so it's quite likely that a patient that you see in the clinic who's over age 60, at a minimum, is taking a baby aspirin and maybe taking one of the more powerful drugs as well. And so it's incumbent on us to know these drugs. We need to know what the thromboembolic risk of stopping these drugs is, and we need to know the bleeding risk of keeping the patients on these drugs. And so the surgical decision-making has gotten ever more complicated. We'll review that decision-making in this talk. And lastly, our medical colleagues can be really very helpful here, especially cardiologists, since they're often the prescribing physicians. Before we talk about surgical decision-making, I think it will be worth our time to briefly review the common antiplatelet and anticoagulant drugs that are in use in 2021. Aspirin is commonly prescribed for cardiac and stroke prevention, and it's often combined with Plavix in patients with cardiac or vascular stents. When aspirin is prescribed for its antiplatelet effects, it's usually given in the low-dose version. Aspirin works by irreversibly inhibiting platelet aggregation. It does this by interfering with thromboxane production, which is a potent platelet aggregator. The duration of action of aspirin is about a week, and there is no reversal agent. Aspirin can often be safely continued in low bleeding risk patients. Plavix is another irreversible platelet inhibitor with a duration of action of about a week. It's commonly combined with low-dose aspirin to prevent cardiac and vascular stent thrombosis. In elective surgery, if the bleeding risk of the procedure is felt to be high, the Plavix will usually be stopped 5 to 7 days before the case. The low-dose aspirin can often be continued through this time period. The Plavix should be restarted as soon as feasible. Often this will be the day after the procedure. Let's now review some of the common anticoagulant drugs. Heparin is a naturally occurring glucosaminoglycan that comes in both IV and subcutaneous formulations. Heparin works by greatly increasing the activity of antithrombin 3, which is a circulating anticoagulant. The activity of heparin is best monitored by the partial thromboplastin time. And generally, we're shooting for a target value of 2 to 2.5 times the control range. The half-life of heparin is about 1 hour. Around the hospital, it's commonly used to treat acute deep vein thrombosis and pulmonary embolisms. It's also used during cardiac and vascular procedures and during dialysis sessions as well. If the patient is going to require more than 1 or 2 doses of IV heparin, a continuous infusion is preferred over bolus dosing, since this will reduce bleeding complications. If bleeding is a problem with a patient on heparin, then protamine is an effective reversal agent, and 1 milligram of protamine will reverse 100 units of heparin. The only use for subcutaneous heparin is for DVT prophylaxis. A major limiting factor of heparin is the development of heparin-induced thrombocytopenia, which can occur in up to 5% of patients. Low molecular weight heparins consist of small fragments of the larger unfractionated heparin molecule that we just talked about. Low molecular weight heparin binds to and activates antithrombin 3, just like the unfractionated molecule. This leads to decreased factor Xa activity. Low molecular weight heparins, however, have no effect on thrombin, unlike the unfractionated version. There are several real conveniences to using low molecular weight heparins. First is that monitoring by the partial thromboplastin time is not necessary. And the existence of subcutaneous therapeutic dosing means that many patients can be treated for their thromboembolic disease as outpatients. Low molecular weight heparins have much less reliable protamine reversal if that were ever to be necessary. Another great benefit of low molecular weight heparins is that they cause less heparin-induced thrombocytopenia than unfractionated heparin. Warfarin, or Coumadin, is a commonly prescribed oral anticoagulant. Its most common uses are for stroke prophylaxis in patients with atrial fibrillation, to help prevent mechanical valve thrombosis, and to treat established DVTs and PEs. It works by inhibiting the vitamin K-dependent coagulation factors 2, 7, 9, and 10. Coumadin is an extremely difficult drug to work with. It has numerous drug-drug interactions and very unpredictable bioavailability. This means that it will have to be frequently monitored by the prothrombin time. Now, somewhat paradoxically, you can see thrombosis in patients on Coumadin. Fortunately, this is rare, and it develops because protein C and protein S are vitamin K dependent anticoagulants, and they're also inhibited by Coumadin. So if these factors were to be inhibited relatively more than the coagulant factors, you could see paradoxical thrombosis. If it's necessary to reverse the effects of the Coumadin, oral vitamin K will generally normalize the prothrombin time within 24 hours. If one needs quicker reversal, then IV vitamin K along with prothrombin complex concentrate will generally do the trick. A relatively new class of anticoagulants are the direct factor Xa inhibitors. As their names suggest, these drugs bind directly to activated factor 10 and inactivate the drug by that route. Xarelto and Eliquis are the two most common factor Xa inhibitors in clinical use, but there are other drugs in this class as well. The major uses for these drugs are stroke prevention in patients with atrial fibrillation and to treat patients with thromboembolic disease, ischemic heart disease, and patients with heparin-induced thrombocytopenia. There are some contraindications to using these newer drugs. They should be avoided in patients with mechanical heart valves, since the thrombosis rate is higher than in patients taking Coumadin. They should also be avoided in patients with severe liver and kidney disease, since the drugs are metabolized by these routes. And these drugs should also be avoided in pregnant women, since the drug was never tested on this class of patients. The direct Xa inhibitors are very commonly prescribed nowadays because they offer many advantages over Coumadin. Some of these advantages include a very predictable bioavailability, and this means that there's no outpatient lab monitoring required. These drugs have very few drug-drug interactions. They also come in fixed doses, so you don't have to spend any time at all to figure out what is the right dose for your patient. They have very short half-lives, roughly 12 hours, so this is quite convenient if the drug needs to be stopped before a procedure. And if emergency reversal is required, Andexanet alpha or Andexa is now available as an antidote. There are a few disadvantages to these drugs. They're quite expensive, and although generally no lab monitoring is considered an advantage, this can be problematic in non-compliant patients because there's no way to monitor if they're actually taking the drug or not. And also, the fixed dosing can be a problem in very obese patients since no one's quite sure if the fixed dosing regimen works in this group of patients. Direct thrombin inhibitors are another relatively new class of anticoagulants. They work by directly preventing the conversion of fibrinogen to fibrin. Around the hospital, the IV drugs are often used in lieu of heparin, and so they found use in the cardiac cath lab, and sometimes they're used for the IV treatment of heparin-induced thrombocytopenia. These drugs have a very short half-life, and if monitoring is necessary, it can be done via the PTT. There's only one oral direct thrombin inhibitor. That's dabigatran or Pradaxa. It has very similar pros and cons as the direct 10A inhibitors. Its half-life is 12 to 17 hours, and now there's an emergency reversal agent called Praxbind that's available for clinical use. So that was a brief synopsis of most of the common anticoagulants that we will see in clinical use. Let's now switch gears and talk about the perioperative management of these drugs. When a patient is referred to a surgeon for a necessary procedure, and this patient is also taking an anticoagulant, the challenge is to find the balance between minimizing the risk of thromboembolism and minimizing the risk of excessive bleeding. This is something that has to be done on a case-by-case basis, and there's no app that will calculate these risks for you. It has to be based on your own experience and your own clinical judgment. The general approach will be to first estimate the thromboembolic risk if the anticoagulant is stopped. So, for instance, if a patient has a mechanical mitral valve or has a cardiac stent, then the potential risk of thrombosis here could ultimately lead to death. And so that risk is going to have to be factored in. We also need to know what is the procedure bleeding risk. Some procedures are inherently more risky than others, and we need to know if we kept the patient on the anticoagulant, how would that increase the bleeding risk? And so ultimately, we need to decide whether the anticoagulants need to be stopped, and if they do need to be stopped, when should they be stopped? Bridging is sometimes done in patients who are taking long-acting anticoagulants like Coumadin, and we don't want them to be off this drug for very long. So we start them on a short-acting drug like Lovenox, which then can be discontinued right before surgery. And lastly, I have no expectation that surgeons should make all these decisions by themselves. We need to use our medical colleagues for all they're worth. In general, a cardiologist is going to know much more about the type of cardiac stent that's in place or the type of mechanical valve is in place, and they will know highly accurately what the thromboembolic risk is if we stop the drugs. And so they can be very helpful in estimating risk, helping us to decide whether the anticoagulation can be safely stopped or not, and whether bridging should be employed in this particular patient. So in this circumstance, the perioperative management of a complicated patient is definitely a team event. There are multiple medical conditions that are associated with an increased thromboembolic risk. Some of the ones that we see frequently in the clinic are patients with atrial fibrillation, patients with prosthetic heart valves, patients who've had a recent arterial or venous thromboembolic event, patients with ischemic heart disease, or patients who've had a stroke or TIA. In the perioperative period, the mortality from a valve thrombosis may be as high as 17 or 18%, and the mortality from a perioperative stroke may be as high as 37%. That has to be counterbalanced by the mortality risk from a major bleeding episode, which may be as high as 10%. Now, these bleeding episodes would usually be in a major body cavity like the abdomen or retroperitoneum or the chest or the mediastinum. You're not going to get a mortality from a subcutaneous hematoma. For patients with atrial fibrillation, there is a way to calculate their annual risk of a thromboembolic event. There's a risk calculator called the CHADS-2 score, which takes into account several known thromboembolic risk factors. These include congestive heart failure, hypertension, age greater than or equal to 75, diabetes, or whether the patient has had a previous stroke or TIA. And so these risk factors can be added up, and the patients can be stratified into low risk, moderate risk, or high risk categories. This information is definitely helpful and is used quite frequently. The information will be used to decide whether the anticoagulation can be stopped or not, or whether bridging will be required. There are two types of prosthetic heart valves in clinical use: mechanical valves and bioprosthetic valves. Patients who have a mechanical valve in place will require lifelong anticoagulation to mitigate the thrombosis risk. They'll usually be on Coumadin for this. Any patient with a mitral valve is considered to be at high risk for thromboembolism. There are also some aortic valves that are of the caged ball or tilting disc type, but these aren't in common clinical use anymore. And so most patients with aortic valves are felt to be at low risk for thromboembolism. A patient with an aortic valve and atrial fibrillation, a fairly common clinical occurrence, is in the moderate risk category. Bioprosthetic valves are being placed much more frequently now. These are porcine or bovine valves, and they only require 3 to 6 months of anticoagulation. If you're unsure of what type of valve your patient has, you can just look at their chest. If they've had a sternotomy, they've had a mechanical valve placed. If the valve was placed percutaneously in the cath lab, then they have a bioprosthetic valve. And so the general approach to someone with a bioprosthetic valve is to try and delay elective surgery for 3 to 6 months. If you need to do an emergent or urgent operation in this 3 to 6 month window, generally it's safe to stop the Coumadin and no bridging is required. But I do highly recommend you discuss all this with the patient's treating cardiologist. If a patient has had a DVT or PE within 3 months, they're at high risk of another episode if the anticoagulation is stopped. After 3 months of anticoagulation, the annual risk drops down to about 15% a year. So in general, we want to wait at least 3 months for elective surgery in someone who is currently being treated for a DVT. But we also need to consider additional risk factors as well. For instance, why did the patient get the DVT? If they have a malignancy, that may need to be addressed as well. Cardiac stent placement is a very frequent treatment for ischemic heart disease. And virtually all of these patients will be on aspirin and Plavix post-procedure. Discontinuing these drugs results in a very high risk for stent thrombosis, and this can be a highly lethal event. If the patient is referred to you for an elective type procedure, you'd want to wait at least 14 days if they just had an angioplasty. You'd want to wait at least 30 days if they had a bare metal stent placed, and you'd want to wait at least 1 year if they've had a drug-eluting stent placed. Of course, you're likely to have to talk to the patient's cardiologist to find out what kind of stent was placed, and you'll definitely want their advice about whether these drugs could be discontinued or not. If the patient needs an urgent or emergent procedure, the cardiologist is going to have to be involved in the decision to stop the antiplatelet drugs. If the decision is made to stop these drugs, there should be 24-hour invasive cardiology at the institution in case the patient needs an emergency trip to the cath lab post-op. Patients who've had a stroke or a TIA are usually on low-dose aspirin for prevention, but sometimes Plavix is added to this regimen as well. Besides the stroke risk, patients who've had a stroke also have a very high risk for cardiac complications. In general, the risk of cardiac complications seems to plateau after 9 months from the stroke event. So ideally, we delay elective surgery for 9 months, if any way possible. After we finish assessing the patient's thrombotic risk factors, we need to turn our attention towards estimating the bleeding risk from the proposed procedure. This is something only the surgeon can do. This responsibility cannot be delegated to any of our medical consultants. We are the experts in these procedures, and we know their particular risks. Besides the invasiveness of the procedure, we also need to take into account the consequences of bleeding if it occurs. Subcutaneous bleeding is annoying, but not particularly dangerous. On the other hand, intra-abdominal or intrathoracic bleeding can potentially be lethal. Besides the procedure itself, we also need to assess the patient's comorbidities, since things like liver disease and kidney disease will also increase the inherent bleeding risk. As a general rule, low-risk procedures will not require stopping the anticoagulants. So skin cancer excisions, routine inguinal and umbilical hernias, and even some elective cholecystectomies can safely be done with the patient continuing their anticoagulants through the perioperative period. On the other hand, cardiac, vascular, and intracranial procedures are particularly risky from a bleeding standpoint, and the anticoagulants are going to have to be stopped for at least some period of time. The decision on whether to stop anticoagulation or not must be made on a case-by-case basis. The surgeon and any relevant medical consultants should be in full agreement on how best to proceed. And it's extremely important to keep the patient informed of all the thoughts that go into the decision making. Patients need to understand the pros and cons of stopping the drugs or keeping them on it, since ultimately it's the patient who has to pay the price with any complication that develops. In low-risk cases, usually the safest thing to do is to keep the patient on the anticoagulation. That will minimize the thrombotic risk, and any bleeding complications should usually be relatively easy to take care of. In higher risk bleeding cases, the anticoagulation is going to have to be discontinued, but the period off anticoagulation is going to need to be as short as possible. If a patient is taking Coumadin, and this needs to be stopped before surgery, then a reasonable protocol is to discontinue the drug 5 days before surgery. You would then check the INR the day before surgery, and we're looking to proceed when the INR is less than 1.5. If the INR is greater than this level, then low-dose oral vitamin K will usually bring it into range. Now, if it's a particularly high-risk patient for thrombosis, we may want to minimize the time that they're off Coumadin. In this case, we'll start a bridging agent like Lovenox 3 days before surgery. We'll talk more about bridging in just a second. Coumadin can usually be restarted post-op once the patient is able to take oral medicines. Oftentimes that will be 12 to 24 hours after surgery. However, it can take a long time in some patients to get the INR up above 2, especially if they had to have some vitamin K to get the INR down. In this case, they may well need a bridging agent post-op as well. For patients taking one of the factor Xa inhibitors or thrombin inhibitors, a reasonable approach to managing their anticoagulants is as follows. If the proposed procedure is associated with a minimal bleeding risk, then you just need to discontinue these drugs on the day of surgery, and they could be resumed either later that day or the following morning. If it's a low or moderate risk bleeding procedure, then generally we'll have the patient stop the drug the day before surgery, and we'll restart it the day after surgery. If the bleeding risk is felt to be even higher, then we'll discontinue the drugs 2 days before surgery and restart 2 days later. Now, post-op, if the GI tract isn't going to be available for several days or more, then we may need a bridging agent in this case as well. We've mentioned bridging anticoagulation several times already, so let's describe what it is and how it might be used. The goal of this is to minimize the time the patient is not anticoagulated. And so it's used when there's a very high risk of thrombosis once we stop the anticoagulants. And so as a practical example, let's say we have a patient who's taking Coumadin. Generally, we'll stop this 5 days before the procedure. If they're high risk, we may want to start a short-acting agent like Lovenox, and this will generally be started on the 3rd day before the procedure. We would then discontinue the Lovenox 1 day before the surgery. Following the surgery, we'll have to make a decision about bridging during this time interval as well. It can take a while for a patient to get therapeutic on Coumadin once it's been stopped. And so the bridging agent may well need to be continued for up to a week post-procedure. Now, if the patient is in the hospital and is being bridged with IV heparin, since this drug has such a short half-life, it can be stopped several hours before the surgery. And so bridging anticoagulation definitely lowers the risk of perioperative thrombosis, but it also increases the perioperative risk of bleeding. So it requires good judgment as to what patients need this procedure and which can safely avoid it. Some clear-cut indications for bridging anticoagulation would be any patient who's had an embolic stroke within the last 12 weeks, or who has a mechanical mitral valve, or any patient with a mechanical aortic valve and additional stroke risk factors. Atrial fibrillation and additional risk factors of stroke would be another indication, as would venous thromboembolism within the last 12 weeks, and anyone who's had a recent coronary stent. You would resume the post-op bridging once hemostasis for the particular case is assured. Here's a list of the references I used to put together this talk. Thank you for your attention. The next topic in this series will be the preoperative assessment of the surgical patient.